Hello and welcome here at EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel. And in this live video session, we're going to try to answer as many of your questions on the topic of alveolar ridge preservation. I'm very honored and glad to be joined by our tonight's expert, which is Professor Ronald Jung, who is the head of implantology at the University of Zurich in Switzerland. Professor, good evening.
Good evening, Gerrit.
Yes, I'm very glad that you're with us tonight. We've chatted about this topic quite a bit already. But before we start in these special times, I'm curious to know how is the situation currently for you in Switzerland? Is your clinic back open?
Yes, actually, since last Monday, as a Monday for a week ago, we basically are running the clinics in a more or less regular way with some more hygiene restrictions, and really it does feel so good. So I was kind of driving my car into university and was singing and so happy to just go back to normal life. So it feels good.
Nice. Well, for those viewers who are here for the first time, let me briefly explain how this works. I already see a lot of people participating in our kind of opening chat where I've asked all of you, please let us know in the chat on the side of your window who you are and where you're joining us from. And we see some regular names, some very loyal followers from the community, but also some new ones. And the audience is already quite diverse and quite international. Starts with Alice from Paris in France, Christopher Appelquist from Sweden, Alberto Sogado from Alicante in Spain. We have Madel Mohammed from Algeria, Anna Klinger from Stockholm, Bruce from Northern Ireland, and so on and so on. So please read through that list, feel that sense of belonging and community that we have here tonight. And this is actually also the same feature that you can use if anywhere during this broadcast you have a question. Type in the question into the chat here, and I will relay your questions to Professor Ronald Jung as they come in. But before we do so, let's start with a little introduction. Alveolar ridge preservation. What are we talking about tonight?
It's a topic which is maybe one of the most emotional topic in every patient's life. Just today, I had the pleasure or the pressure to extract a tooth of a pretty prominent person, and I realized how much this person was emotionally stressed about the situation of losing a tooth. So I think within every dental treatment, also knowing that you're going to lose a tooth, it's a stress because you're going to lose part of your body. And this is something which we as dentists should really take into the consideration, that it's not kind of just a treatment. It's a treatment which we need to show us a lot of empathy to the patient in order to not make it small, but kind of really show how much we feel what it means to lose a tooth. And the more anterior a tooth is, the more kind of emotional it becomes. And I think it's one of the most serious topics we should talk about. And the overall aim today is really kind of to provide you with really very practical information which enables you to make the right decision for the majority of the situation when it comes to the point where I need to extract the tooth. And that's actually the whole thing, that really kind of wrap up the whole thing by providing you with really clear directions what to do in which clinical situation.
Yeah, because the alveolar ridge preservation fits in right after extraction, right? That's where you make a decision in the protocol. Do we take extra measures for ridge preservation or not? Could you please, perhaps with some slides, show us a brief introduction into where this takes place and what the dilemma or choice is that we have in our clinic?
Yes, I'm happy to do this. But before doing so, you actually point out something very important, Gary. You said that happens after tooth extraction. I think everything we talk about today, it's the most important thing that it happens before going to extract the tooth. Extracting a tooth today in modern dentistry, I would not say in modern implantology or oral surgery or periodontology, tooth extraction should be part of the overall treatment plan. And you should never extract a tooth without having a clear direction in which direction we'll go to. So the time where it's 11:45, patient comes in as an emergency and you see, okay, this tooth needs to be taken out, that's a thing of the past. These teeth should not be taken out before 12 o'clock, before you have done a proper kind of overall treatment plan. And then tooth extraction is one part of the overall treatment part. So therefore, the whole story starts before I'm going to extract the tooth.
Exactly. Important
So
takeaway number one. Start with a plan.
That's definitely an important part. Now I prepared some slides and I brought two girls with me, Gerrit, just for you. And we would like to dig into the topic of alveolar ridge preservation, but it's not about alveolar ridge preservation per se. It's really about the decision-making process before we're going to extract the tooth. And as I told you, I brought two girls with me, and these two girls, they kind of illustrate very nicely the importance and the impact of what's going to happen when I'm going to extract the tooth, when I do it right, or maybe do it not that right. This first young girl, her name is Laura. She's 12 years old, and she's a very energetic girl, and she loves bicycles. She loves it so much that she goes every day with her bicycle to school, and she meets with friends with her bicycles. And obviously, what happens sometimes that she's falling with her bicycle. And unfortunately, already 1 year ago, she lost one center inside her. And now, believe it or not, she's going to lose her second center inside her. And her parents think, oh no, I cannot believe. My daughter is 12 years old and she already lost her two central permanent teeth. Mm-hmm. So she has been treated about 10 years ago in one of the pediatric practices in Zurich, Switzerland. And they did what they usually always do. They look at the situation and they saw, okay, this tooth has a fracture. Then they extracted the tooth, as we can see it here, very gently in order to not kind of destroy anything around. And that's basically the situation of the tooth extraction. Now, Gerrit, what do you think? What's going to happen now with this hole there?
Well, I have a little information from our talks before, but I think it's going to heal, right? I mean, if we do nothing, this is going to heal and close, I think.
Yes, so we gained a lot of know-how in terms of what's going to happen after tooth extraction. And in this particular way, we'd like to talk about really wrong decisions. And I would like to show this with this cone beam CT of another patient, because we usually don't do any cone beam CTs on such young patients, but it illustrates a very similar situation as we can see here on the left side. And with this patient, what we did, we kind of can see here the buccal bone plate. This is the extraction socket. And let's consider it in the front area a pretty thick buccal bone plate. It can be much more thinner or deficient. And we did that X-ray just immediately after tooth extraction. And then we did another X-ray, cone beam CT, 6 months down the road. And now with modern technology, we can visualize what's going to happen between these two time points. And that's what we're going to see here. So when we look at this situation, we can see the changes taking place within a 6 months period. And I think I love this video, because when you have seen this video once, you will never forget it as a dentist, because these are so dramatic changes taking place within this area, which we should never let it happen without doing anything or just closing our eyes.
Yeah, so basically what we see here repeated a few times is that the entire bony structure around the socket disappears in 6 months, you say?
Exactly. So nature is just doing what's logic, because when something is not going to be used anymore, it's not under function, nature tries to reduce the volume. And we have to give a lot of credit to Jan Linde and Maritia Lujo. They started actually the whole research in particular focusing on trying to better understand what's going to happen after a tooth extraction. And with them, we gained a lot of know-how in terms of how much approximately we're going to lose. And this varies between 30 to 65%, whatever, but a kind of the number to remember, easy to remember, is actually that we roughly lose in an anterior area about 50% of the buccal oil volume. That's something which I consider to be knowledge which should be known by every dentist. You don't need to be a surgeon.
6 months. Let's repeat it one more
time. That's about what we should definitely always should remember. Now, this is Laura now 9 years later, as she came back. And she's now 21 years old. She is still very energetic. And she has now a boyfriend. And since this time when she lost her teeth, she's wearing a removable provisional denture. And she's sick and tired of this denture. And she so much looks forward to kind of nice fixed teeth. Now, when I asked her to open her mouth, that was this clinical situation which you could see after this time period. And I think you already could assume, and as you already see, Gerrit, that we really lost so much volume there, 50% or even more, because it's individual. This is just the outer situation. When we then go into the situation, when we look at the bony situation, where it is intended to place implants, we can see that if you have just a very narrow ridge left, this is actually what is left here. Mm-hmm. And here it's this part. So it is basically impossible to place an implant. That means we need to recreate what has been lost 11 years ago by very invasive techniques. And in this particular situation, we did that by harvesting harvesting bone from the chin area, mm-hmm. and to augment this area. This is a very well documented technique, but it's heavily invasive for this situation. And it's also very traumatic for the patient, but it's also stressful for the dentist per se. We also should consider today providing techniques which makes it less stressful for dentists, which makes it less technique sensitive, which allows that more patients worldwide can profit from more simple and straightforward, or not even simple, kind of less technique sensitive techniques.
Exactly. You're reducing complexity if you can avoid the bone regeneration. That's what you're saying.
Exactly. So this was the story of Laura. And now, as a modern dentist, we ask ourselves, what can I do against this alveolar-rich resorption? And how can I become less invasive? And again, that I don't need to sweat during a treatment. So with this, I would like to introduce you to Caroline. Caroline is 15 years old. She's also very energetic, and she loves swimming. She goes every week into a swim club, and they also play around. And once she jumped into a pool, and by doing so, she just fractured both her central incisors. And she lost them. Now, she has been then treated at the university clinic at that time, and she has been treated in a different way. After cleaning the extraction socket, these extraction sockets have been filled up with a graft material. And then, in order to cover them, 2 autogenous grafts have been harvested from the palate. You can see it here, mm-hmm. by using a punch, and has been sutured around there. And this is how it looks like then 1 week later, where we can see that the majority is nicely integrated. We see here some fibrous tissue, because it's a healing which is not kind of like a primary healing there. It needs to have parts which have a secondary healing. And this is the situation from the buccal view. Now, this was then Caroline when she came back, when she was 20 years old.
5 years later. Yeah.
Exactly. She's not that energetic anymore. Mm-hmm. And she has not yet a boyfriend. But she's desperate to get one. And she's also sick and tired of her removable denture, and she wants to have nice teeth. Now, when she's open her mouth, that's the situation how it has presented. We do see some remodeling, some kind of different ridge areas. But when we open this kind of ridge, we see a completely different situation here. We see some irregularities, but we see that we have enough bone to place these implants. Here we did a guided implant placement. So we did beforehand a 3D planning, and then 2 central implants at the perfect prosthetic position have been placed. This is how it looks like then after placing these implants, which have been placed completely within the bony envelope. Now, when we go back to these 2 ladies, This is Laura on the left side. That's her clinical situation. And this is Caroline on the right side. What is basically the difference between these two ladies, Gerrit?
Well, I would say Caroline has received a rich preservation protocol, right?
That's true. But basically the difference, that's the most important part to realize, is not that she received a rich preservation protocol, because she would never ask you as a dentist, please, can you give me a rich preservation? They both came and they want to be treated in the best way possible. The difference between them is the dentist. Because the dentist is the one which can make these lives completely different. This single one decision which needs to be taken at the time of tooth extraction or at the time of tooth extraction about just leaving it as it is, like Laura or Caroline, has changed their lives within a 1.5 year period completely different. Because the dentist has not done the right decision with Laura. She had to undergo an extremely invasive, very stressful procedure, has to wait much longer in order to receive then her implants and finally her crowns. Whereas Caroline has a completely different protocol. She has a much more straightforward protocol. And the difference between these two ladies is only the fact that the dentist has done the right decision at the time of tooth extraction. So with this, I think it's very important and nice to see the importance of us taking the right decisions. And it's not about a technique per se. Mm-hmm. It's about making the right decisions. That makes the dentist successful or not. It's something which we need to realize that it's our responsibility, and decision-making process is therefore maybe the key for successful implantology or in general dentistry.
Wow. Impactful story. Thank you very much for sharing that first introduction. In the meantime, welcome to all our viewers who are joining us literally from all over the world now. Ronald, there from Italy, Philadelphia, Brazil. I see Portugal present, Macedonia, Moldova, Saudi Arabia, and even Tokyo. So we truly have a global span right now. And let me all invite you once again, after hearing this introduction, hearing this message about always having a plan ready and making the difference in your patient's lives as a dentist, what kind of questions does that raise? Do you have any experience with rich preservation? Or if you don't, why haven't you tried it? Or what's holding you back? Use the opportunity that we're live tonight. Send in your questions and we're going to pose them. And there's a first question coming in, so let's take that straight away. It's from Mario Escobar, and he's joining us from Ecuador. So I think we should say good early afternoon, I think. And he's writing, well, if we have that result with rich preservation using biomaterials and CTG, why placing the implant and not just making a Zirconia Maryland bridge approach? Why, if you can do this already with the rich preservation technique, why would you even go for implants later on?
I think this is up to each individual case, whether it should go in the direction of a resin bonded bridge or in the direction of an implant. I think we just had 2 weeks ago a very nice webinar from Harvard University that we kind of compared the impact when we should go for an implant, when we should go for a resin bonded bridge. I think we cannot just kind of give a general recommendation. It is true, and I think it became a very nice instrument to use resin bonded bridges in implantology, so to say, because it's often a rescue scenario which can be used in a situation where we have failing implants, where we have really large bone defects, whatever. But we have to face the fact, especially when we have 2 missing central incisors, that's not an ideal case for a resin bonded bridge. Because the ideal indication for resin bonded bridge is actually the lateral incisor, where we also have most of the documentation about. Daniel Edelhoff, the professor in Munich, he did a nice research about specifically focus on lateral incisor and resin bonded bridges. There we do have evidence. But replacing a central incisor and even 2 central incisors, where we have the backings that would be needed to glue to the lateral incisors, where we have kind of a small surface, restoring a much larger tooth, that's not an ideal situation. And I would go even that far now, talking as a prosthodontist, as I also am. I would consider this then more as a long-lasting temporary reconstruction, and not considered to be really kind of a permanent reconstruction.
All right. Well, thank you for sharing that. And thank you, Mario, for sending in your questions. This is how it works tonight. If we continue a little bit deeper into exploring this topic, Professor Jung, you mentioned the word science. What do we know about outcomes? What do we know about potential complications with this technique? Because it is relatively young, right? It originated in the early zeros and tens.
Yes. So there are two questions. On the one hand, you kind of ask the evidence for the technique per se.
Yeah, let's start with that.
And we can say that this is a topic which have the interest increased significantly over the last years. And the best way to look at evidence is always then kind of looking at systematic reviews, which are primarily kind of generated within a consensus conference. And maybe one of the most significant consensus conferences is the EO consensus conference and the European Federation of Periodontology. And especially we look forward for an EO consensus conference in the upcoming 2021 in February. And last year we had one from the European Federation of Periodontology, where we wanted to look at the latest and most current evidence on ridge preservation. And there we ended up by the fact that we can say, yes, we do have now a lot of evidence that ridge preservation does have an impact to significantly reduce the amount of volume loss compared to situation where we have left for spontaneous healing. And we can quickly look at some studies there. And on the other hand, we could not identify one single material which enables us to be on top of others. But we could identify actually two main materials which have the best documentation. And this is on the one hand a bovine bone mineral, and on the other hand, an allogenetic materials. These are the two best documented materials. But I'd like to share with you, Gerrit, I think that's something which you might like, a study where we were one of the first studies which did a comparison between different treatment modalities for ridge preservation. In this study, which has been published in 2013, we had basically 4 different treatment modalities. On the one hand, as a control, which is always important, we have the spontaneous healing. Then on the other hand, we had used a group with a xenogenic graft material embedded in 10% collagen and a punch graft on top. So similar as we have seen before with Caroline. Then we have one group which we did the same graft material, but with a collagen matrix. And then we have one group which was kind of introduced specifically for ridge preservation using material which consists out of tricalcium phosphate, which doesn't need to be covered according to the manufacturer's recommendation. It can be left open.
Okay.
And
now,
the idea
before
was,
you share the results of this comparison, let me point out that I took down your slide share. So I see you're talking to the slide, so you need to relaunch the slide quickly.
Okay.
So we actually look at that comparison as well and then see what they found.
Can you see this?
No, you have to start the share once again.
Okay.
So in the Zoom application. In the meantime, we see a lot of questions coming in with our very international audience. So hold on, I will relay the questions first. Let's first finish this introduction of the different materials and the results that were found on that.
Now you can see it again.
Perfect. Yes, we're back.
So when we look at the situation here, on the one hand, we checked on the horizontal changes on different levels. -1 millimeter from the top, -3 and minus 5 millimeters. Here we have the control, which is the spontaneous healing. And we can draw our line again of 50%, which is actually our reference. And also we could see here, we are close to this 50%, so we are in line with what we have seen in other parts of the world. Mm-hmm. Then there are two big surprises. One surprise was that the TCP material here was even losing more bone than the spontaneous healing part. That was kind of really almost a shock by seeing this using a graft material. Mm-hmm. And we started to discuss what can be the reasons. And today we just can hypothesize about that. But we do believe, and I think when we talk to all the experts worldwide about the experts on alveolar ridge preservation, we do believe that TCP is a too fast resorbing material. Okay. And therefore, the material is going to be resorbed within 2 to 3 months. And this time period is actually the time period where most of the remodeling process takes anyway place within the extraction socket. So having this material there, which the body needs to get rid of the material, is kind of together with the time where the body is going to remodel the bone. And it seems to be that like the whole process has been like accelerated there, and therefore we lose even more bone than without having any graft material in there. By using then a xenogenic material, we could significantly reduce it to about 17%. Mm-hmm. But we have to face the fact, and that was also visible when we look at Caroline's case, by just placing graft material inside the extractor socket, we will never be able to maintain 100% of the result. That's a very important take-home message as well. So when we are dealing with a very demanding aesthetic case, we always need to kind of additionally graft to the outside of the bony envelope to compensate for this last 15%. And the third kind of surprise was the fact that actually the autogenous graft and the collagen matrix kind of behaved similarly when it comes to the horizontal changes. It did not behave similar when it comes to the vertical changes. Here we can see we do have a little bit of an increase of the soft tissue thickness when it comes to the autogenous graft compared to the collagen matrix, where we lose about 3% of the height. And also here you can see again, this is what we have seen with the autogenous, with the spontaneous healing, where we lose about 11%. Also, this is in line with systematic reviews. And the TCP material, which is so fast resorbed, did resorb more than the spontaneous healing part due to the possibility, what we hypothesized, that we really kind of heat up the process there, having more inflammation cells which need to get rid of the particles, and in the meantime also get rid of more bone.
Clear. So choice of materials matters, but in general there is science behind this and showing that this works. Now I see quite some questions about, can you shine some light on the timing, right? So where and when in the protocol, what is the effect of ridge preservation on timing? After how much time can we continue or go back? What can you say about that?
So timing is a big thing. How long should we wait when I'm going to do an alveolar ridge preservation procedure? We have different studies which have chosen different time points. As I said, Maritia Lujo from Brazil, he's really one of the pioneers and the expert when it comes to alveolar ridge preservation. He's a great friend and really a very clever scientist and a great clinician. And he has chosen actually a protocol with the same materials, but he's waiting 4 months until his reentry. Another RCT from Italy, which has been also using similar materials as we have used, they have waited 5 months. And we in general have waited 6 months before we go in again to place our implants. Now, when we try to look a little bit into science, there is one study in Journal of Periodontology 2010, which did biopsies at different time points. after 3 months, and after 6 months after alveolar ridge preservation procedures. And they found out that after 3 months, I have a distribution of about 40% of connective tissue and non-mineralized tissue. Can be anything at that time point. 46% new bone, and 15% the residual graft material. Now we are curious about how does it look like after 6 months. And after 6 months, we were surprised by seeing almost the same numbers.
Yeah.
So it seems to be that after 3 months, kind of an already kind of a good maturation has started by having a similar distribution after 6 and 3 months. Now this is science, but we are primarily also clinicians. And from a clinical point of view, I can tell you that it does make a difference in terms of the drilling feeling when you do this. So after 3 months, this is still bone, and it still will be turned into bone, but it is not as solid as it is after 6 months. So it does feel a little bit different when you do the drilling procedures, and it's not for everybody kind of the same good feeling. So waiting longer does help to even, I would say, simplify the procedure by having a similar perception as I do when I'm doing a regular implant placement into sufficient bone. So whenever I have the time, I actually prefer to wait a little bit longer. I think when we're gonna show and discuss about more other cases, I can show you, I think time is not as important there, because many situations, just individual patient situation anyway, ask us for waiting longer. But when I can choose, and when I choose a ridge preservation procedure, I tend to wait until between 4 and 6 months.
Exactly. So partly based on the science and on the clinical practice that you have there and of the feeling. Now, since these slides come up anyway, the second question from Victor Palarie, who we will meet soon on this channel as well, he's saying, so then in this slide, what is your opinion regarding implant placement in a fresh extraction socket in order to prevent ridge dimensional changes altogether? So this, what if we place immediately?
Yes, maybe you can go into this topic here. So at the end of the day, and the most important word up here is this one here, the before, as we said at the very beginning. What we all talk about today is we need to take the decision before I'm going to extract the tooth. And the 3 options I basically have when I'm going to extract the tooth are, number 1 is that I leave it for spontaneous healing. How much do I lose, Gerrit?
50% in 6 months.
You're a good.
For those who joined later, make sure you go back in the recording, and this is one of the key takeaways.
And then we have 2 interventions, so-called. Spontaneous healing is not an intervention; you just let it heal. That can also be on purpose, so it doesn't have to be that you always need to do something. And then we have the option of doing an immediate implant, or we can do an alveolar ridge preservation. So when it comes to spontaneous healing, as we have learned, it's about the 50% loss. When it comes to immediate implant placement, we basically have 2 options. Number 1 is we can place our implant without any additional bone augmentation procedure into this fresh extraction socket, or we combine the implant with a graft material in there. And when we'd like now to know a little bit more about these 2 opportunities, I think it's always nice to have kind of the classic literature. There is a more current ones, but Stephen Chen from Australia, the past or still current ITI president, he did a very nice study very early in 2007, comparing these 3 options. He had 30 patients with 30 immediate implants, and he had 10 implants which were just grafted with a slowly absorbing graft material, 10 implants which were grafted and covered with a membrane, and 10 implants which were just placed without any graft material. And he looked at these patients after 6 months and 4 years. Now, when we look at the results of these different scenarios, We can see here the vertical defect reduction and the horizontal defect reduction. And we can see we have a little bit less resorption when we have used the graft material compared to the spontaneous healing part. So there was no statistical significant difference. So that means a defect heals with and without a graft material in there. So from a healing point of view, and we have a lot of evidence of that, an immediate implant heals without additional graft material. Mm-hmm. But when we look at the horizontal resorption, so that comes to kind of more an aesthetic component in it, where we look how much we're going to lose in the buccal oral dimension. That was a nice piece of information because it fits so perfectly into the entire picture. Because we come here to a situation with 48.3%. So what kind of bell does that ring, Gerrit? It's again the 50%.
Exactly.
So the nice thing about that is, what is an immediate implant into an extraction socket without graft material? That's nothing else than a spontaneous healing with a piece of titanium in the center. So nature doesn't make a difference whether there is an implant in or not, because it's not a vital structure. So the whole remodeling process takes place with or without an implant in place. So that gives us the same result. That's a very nice piece of how nicely that fits together. And when we're going to use a graft material in there with and without the membrane, we could significantly reduce it to 15 to 20%. Now, before we have seen the study which I presented you, which we did rich preservation with different materials, and we ended up also with about 17% of resorption. That's again the same thing. A rich preservation is nothing else than an immediate implant with filling up the residual part of the extraction socket with the graft material. That's the same thing. And we end up with the same result. We can maintain, but not 100%. So this study kind of adds up perfectly to this situation where we can say marginal bone defect, they heal predictably whether bone grafts are placed or not. So from a healing point of view, both works. Yeah. But when it comes to the horizontal bone resorption, a significant reduction takes place when a slow resorbing graft material is going to be used with and without a membrane. So that means when we come back to this slide here, we can say the implant without anything behaves in a similar way like a spontaneous healing, because it is a spontaneous healing. Mm-hmm. Let's say, I would say 15 years ago.
Kind of hard to imagine, but the study shows, yeah.
15 years ago, we thought that placing an immediate implant and giving a function back, an immediate function back, might help to maintain the buccal bone plate. That was a painful experience for many clinicians, the fact that this is not the case. It does not maintain the buccal bone plate, because the buccal bone plate is maintained by the alveolar structure, by the periodontium, and when the periodontium is gone, then we don't have a buccal bone plate anymore. And by doing an implant with a graft material, we end up in a similar situation as we have seen it before by using a rich preservation procedure. So that means that has also his indication, and we can talk later on when we're going to go a little bit deeper into the cases, when we're going to use which technique. And immediate implant is a very valuable and a nice intervention, which I like, but it needs to fit into the overall concept.
Mm-hmm. So can then carefully, if we combine these insights in this little algorithm model, or combining these studies, does that then lead to the careful conclusion that grafting and using materials after extraction is always your better option if you want to preserve the ridge?
It doesn't mean that you always need to do it. I think we will come later on. Let's keep it a little bit more exciting. And when we really come to what are the important questions to address before you're going to extract the tooth, which makes you tend to go in the right direction with each case. So I think it's not, alveolar ridge preservation is not always the right choice. It's the whole instruments which we need to be able to play. But we need to know in which situation we need to choose which instrument. And these are the three instruments which we should be able to use, and we can later on then kind of dig in more into the topics of when to use which of these techniques.
All right. Well, before we do that, I first want to attend to some questions because the questions are coming in. So we're going to go a little bit all over the place. I'm scrolling a little bit back up. And I start with the question from Alejandro Vasquez, who says, we say that the ridge remodels within 6 months by not having function after extraction. So why Caroline, with the socket preservation, did not lose the bone equally after the 9 years? I think the 9 years was the case of Laura, but
I'm not sure whether I get the question completely. So when we have Caroline,
yeah, I took down your slides for a second, so you can scroll it back up.
Yes, I can. Do you need to redo it again, or can you do it?
Yeah, you need to redo it because I thought you were going to answer the question, but you were actually pulling up your slide. Yes, there she is.
We do know that the initial time period where the maturity happens is the first 6 months. And after 6 months, there is not that much of activity anymore. So we have some data from studies which go up to 3 years, which we're going to lose about between 0.5 to 2% of the overall volume thereafter. So the action is taking place in this initial time period. So when we have here Laura's with her bicycle, this is what we have seen here. Maybe you can show this. I love this video so much. I cannot look it enough.
Yeah, for those who join us later. Yeah, this is on the left. We see the visualization of the immediately after extraction and then 6 months later.
So this happens during the first 6 months. And you can imagine so much has already happened there. And it then becomes more quiet. And we have about, I would say, as I said, about 0.5 to 2% per year, which we can further lose. So whether I'm going to wait then 1 year or 9 years doesn't make that much of a difference. When I do need to do an intervention, I need to do it immediately. And therefore, to avoid this initial kind of really boost of remodeling taking place.
Clear. Keep the video on so we can see it as many times as we can. I'd like to take the next question from Christopher Applequist. He says, nice cases on these young individuals. Both Laura and Caroline are youngsters. Is there any restrictions to think about when using ridge preservation in a growing individual like these ladies that you show? Is there any problems with ankylosis on the biomaterials?
Yeah, that's a very important point. And I picked these young patients especially because this is a very challenging group of patients. They are, the peak of accidents is actually around 10 to 12 years. So this is kind of the population, the age population, which is facing the majority of accidents. So when your child is already older than 14 years old and still have all the century inside you, your chance is pretty high that he or she will keep them. Mm-hmm. And this population is very challenging by the fact that at that time point, there is no chance to do kind of any larger intervention, not even thinking of placing an implant, but still trying to preserve what we have there available. Obviously, we would need, I'm a scientist as well, so we would need to have a kind of scientific documentation about that. But this is something which we will never get because there will be no ethical committee which will allow us to do kind of research with these young individual people. We can only kind of conclude what we have learned from adults, from all these studies, that biology won't be that different in these young persons. And I think ankylosis doesn't fit to the biomaterial. So ankylosis is something which is something related to a trauma which has happened to a tooth. Mm-hmm. And ankylosis is related to having a periodontal ligament and kind of a necrosis of part or a complete part of a periodontal ligament, where I start to have then a direct ingrowth of bone into the tooth structure. That's how an ankylosing can start. And having no periodontal ligament means that actually an ankylosing is not something which we need to deal with. But there is a certain part which we will never completely be able to understand, whether what's going to happen in these growing individuals. But I tell you the truth, the way I always try to treat every patient is the way I would like to be treated or my kids are going to be treated. And when one of them are my daughter, I would for sure not leave it for spontaneous healing. I would for sure place a graft material trying to reduce the amount of resorption. So something we need to think of medical doctors in a way. Not doing it is simply not an option. Doing it is something which we can at least reduce the amount of destruction of what happening place, with the limitation that we don't have a full scope of the scientific part about this thing. But not doing it is, for me, not an option anymore.
All right. Clear message. And let's challenge that. We see just coming in, fresh one, and then I go back to some older questions. From Kobe Landsberg, challenging the edges of where we use this. Would you use the same procedure when the buccal bone is missing?
Thank you very much. Kobe Landsberg is one of the pioneers, or maybe the pioneer, which has shown the technique with the punch technique, which I have shown initially. So it's really very nice that Kobe, you're part of that Just Ask session. That's a very hot topic about how much residual bone we need on the buccal aspect in order to do this technique. Mm-hmm. The current evidence is based on the fact that all these studies have inclusion criteria where at least 50% of the buccal bone plate needs to be intact. So when I quickly scroll here, that means that we would like to have, like in the case we're here, that we would like to have at least 50% of this buccal bone plate here. This is what you have the majority of the evidence. Uh-huh. Currently, we run a study in the University of Sao Paulo, which we have very close collaboration with Giuseppe Romito and his team, where we're going to include only patient which has a complete loss of the buccal bone plate. And these patients are going to be treated either by leaving it for spontaneous healing or placing a graft material and a collagen matrix on top. And this graft material is actually basically facing then the buccal soft tissue. And we were totally excited to see what's going on. Currently, I can just provide you data on the first 20 patients. Okay. And it from 10 patients which have been treated with ridge preservation and a complete loss of the buccal bone plate, only one patient needed later on a primary bone augmentation procedure to be able to place an implant. 9 others have been able to place the implant. In the 10 cases where I have no buccal bone plate and we leave it for spontaneous healing, 10 times a primary bone augmentation procedure had to be done in order to go on with later on 5 to 6 months later placing the implant. So there is only a trend that also here, in a kind of more desperate situation, we do profit, at least not maybe for a full extent, but we do profit to reduce invasiveness and to reduce the time for the subsequent treatments.
Wow, these are impressive results and kind of a scoop to hear here first on the EEO channel, fresh from the research floor. Obviously, then the interest immediately goes to that 1 out of 10 patients where you did indeed have to remodel afterwards anyway. What is the cause? And that kind of segues into the question we briefly raised earlier. Was there any complication there, or was there not enough graft material, or was there not enough? What happened, or what could happen?
To the ones which did not receive a graft material, or the one which did receive a graft material?
So in the 10 that received the ridge preservation, you said 1 out of 10 actually after that still had to be remodeled, and that leads me to the question. So is this always, how successful is this procedure, or can we expect any complications?
I can feel that Gerrit is kind of desperate to go into the topic of the complications.
Well, because I don't like it if something is just only shiny and beautiful. We need to understand
totally
the edges of this beauty.
So when it comes to the complication, I think we can have complications on, we can maybe look at some issues here. We can have complications on different levels. And one level is the level of the soft tissue. And this is a case which has been done by one of our postgrad students at the University of Zurich. And he kind of tried to do a very nice graft and did a ridge preservation as he have learned it. Now, when I look at this situation, and I'm going to ask now the people, do you think that is successful or not? And why do you think it could be kind of a little bit a difficult situation? You can see here that these graft materials, and again, I want to mention that Kobe Landsberg is the one which really was kind of first doing this, is very much dependent on the vascularization and the nutrition taking place from the side. Because from the bottom, there is basically nothing coming, because here a graft material is underneath. Now, this graft has no contact in this area with this tooth, with the soft tissue, and here it's in direct contact with the tooth. So from these areas, there's no nutrition coming out there. So it can only be vascularized from these areas. And that's not enough for this type of graft. That is the situation how it looks like thereafter. We have kind of a reduction from the buccal and from the palatal part, but there is a graft necrosis in the central part. Mm-hmm. And again, I think the most important part, it's not about the technique. So don't blame the technique. Don't say, no, this technique doesn't work. It's always about taking the right decisions. And this case is not the right case for doing a punch graft because we don't have sufficient nutrition. This case, when an autologous graft should be used, then it needs to be a connective tissue graft, which is larger, which can be further tacked underneath the palatal and underneath the buccal flap in order to get sufficient nutrition. So this is on the level of the soft tissue. Then we can go to the level of the graft material. Also there you can have an infection taking place because often, or in the majority of the situation, there is a reason why the tooth needs to be extracted. And I think we have good evidence that kind of periapical lesions are not that much risky. It's more like periodontal problems because a periodontal lesion is directly related to the tooth. And when the tooth is gone, actually the periodontal pathology will also gone. Because the periapical pathology is a reaction of the bone and the tissue to an infection taking place within the tooth. Well, when it comes to periodontal infections, it's the entire area is involved. And there is a higher risk of complication in a way of infections that the entire graft material can be infected. If this is the case, there is nothing to go around. This is always a situation where we need to completely remove the entire graft material, need to rinse, need to let it heal, and maybe need to graft to a later stage. So these are basically the two levels of complication you have.
That you can expect, yeah.
There's maybe one additional information because this comes each time. When to use antibiotics.
Yeah.
When we look at the science, the documentation, when it comes to a situation where we're going to use autogenous material to cover a graft material and kind of make it really more, that it better seals the graft material underneath and also the extraction stock, which there is some information going on. In this situation, the majority of the studies, they have used antibiotics, including us, and I do this on a regular basis. So when I'm using a graft material on top an autogenous soft tissue graft, then I'm using antibiotics for 5 days. When I'm using a collagen matrix, I don't use any antibiotics because the collagen matrix does allow some liquid exchange through this collagen matrix.
Okay. Thanks. And just to finish off this topic, the two potential complications. What can you say about incidence? Is there any research into that? Is there any clinical experience from you? Is this very rare, or is this something you come across more often?
I cannot provide you with numbers, actually. In our research we did, we haven't seen complication on the level of the graft material. This is also based on the fact that we have a very kind of clear inclusion criteria there. It includes, on the one hand, only teeth which have periapical pathologies, and it includes teeth which have no acute infection. I think that's a big difference by doing it in acute infection where I have pus coming out there, or when I have a chronic infection. The strategy is to have, when there is a chronic and there is an acute infection, before you're going to extract the tooth, you change this acute infection and bring it into a chronic infection, and then extracting the tooth, a thorough cleaning of the extraction socket, and then providing antibiotics. And with this protocol, we actually have very little amount of infection on the level of the graft material. A little bit more frequent can be kind of graft necrosis on top there. That can be in the round of 4%.
Okay. And this relates then to a question from a viewer called Poyan Quo, which came in quite early already. I hope you're still watching, Poyan. But he says, if I see a little bit necrosis after 1 week post-ridge preservation with a socket seal technique, xenograft plus FGG, may I worry about the further bone or soft tissue healing going wrong?
That's a good point. No, I wouldn't, because we can continue in this case. So we have here that we have a partial necrosis, but the good thing is we still seal the graft material on the knees. Also, when this piece of tissue is not anymore vital, it still serves the purpose of sealing the graft material on the knees. That there, the maturation of the mineralization process and the organization of the tissues can go on. And luckily, when we look at the situation, this is how it looks like then 4 weeks later. Also, this part will at the end heal, and it will heal on the knees by secondary wound healing. And I think this is the huge advantage dealing with mucosa and not with skin, because mucosa is so much more tolerant than skin. So the plastic surgeon, they have a much more difficult task to deal with then kind of complication on the skin level. Then here with the mucosa, we do have a pretty tolerant situation. So when it is necrotic there, I just try to kind of keep it as clean as possible, applying maybe chlorhexidine gel on there, and try to take care of this until it has been grown underneath the soft tissue, that we have a closed situation, ending up with a closed situation with a little bit of an invagination, which we wouldn't have had when the graft material would have been properly integrated.
Clear. Sounds like good advice. Another question that came in quite a little bit back is from Edwin Ruales Carrera from Brazil. He's joining us. Regarding the closure, since we're looking at that and on the topic, what approach would you indicate to seal the socket after the use of a bone substitute? And then the real question is there any gold standard to your opinion or to the science's opinion?
When it comes to the seal, I would say that the best documented material is definitely the autogenous graft material. But we do have an increasing evidence that collagen matrices are also serving the purpose of having sufficient capacity to seal the extraction socket for a certain time period. They obviously resolve much earlier. And as you could see in the results I presented there, they are kind of on the same level as the autogenous graft when it comes to the horizontal level. I think we might go a little bit then into the indication here, because I think it sums up many of the questions which are addressed there, and it gives really kind of very clear advices when should we use which type of technique.
Okay.
So this is at the bottom line always what people are interested. When should I use which technique, and what type of material that comes to that situation? This has been kind of documented in the Journal of Periodontology 2000. In 2018, we had kind of a review kind of addressing all these topics, and all this information is actually nicely addressed in this review. Now it comes to one of my favorite slides, and about the decision-making process. And the good news is always, I tell to all our postgrad students, they're fed up hearing that, you only need to remember one single question before you're going to extract the tooth. And this single question is whether it is possible or indicated to place an implant within the next 0 to 2 months. So this is now the story. Before I'm going to extract the tooth, and I'm really very strict about that. I think that should be applied to every patient which is scheduled for a tooth extraction. Me as a dentist, I need to ask myself, when I extract a tooth, can I place an implant within the next 0 to 2 months? Or can I place an immediate implant, or within the next 2 months as a delayed implant? Or is it not possible? Is the patient available for that? Does he have enough money? Is he too young for getting an implant? Does he need to have a periodontal treatment first because his oral hygiene is not properly? All this information needs to come up together. And whenever I can say, yes, everything is fine. Patient is old enough. Patient is available, is not traveling. I have no restriction not placing an implant. There is no need to do an alveolar ridge preservation procedure. Then, in these cases, I either go for an immediate implant when the indication is ready for that, or I'm going to let the soft tissue heal for 6 to 8 weeks. I'm going to place then an implant with a simultaneous bone augmentation procedure. I think that's important to realize that it doesn't mean that always the same size fits all. You really need to customize and individualize your treatment to the individual situation. But now I'm also very clear that in cases where I cannot place an implant, or is it not possible, not indicate within the next 0 to 2 months, maybe I never want to place an implant, maybe because I would like to do a resin bonded bridge, as we had one of the first questions. Whenever I have to say, no, I'm not able to place an implant within the next 0 to 2 months, I cannot close my eyes by saying, I don't know anything about that. Then today, I do think we need to do a ridge preservation procedure to maintain the structure in a most efficient way, knowing that we cannot maintain everything. We can only maintain about 85%, but this is in many situations sufficient to go on with the subsequent treatments. So that's a very important key learning. When we talk about the ones which I cannot place an implant within the next 0 to 2 months, and I can go into some examples then later on, we have a situation that refers to the question about the bone defect from Kobe Landsberg, where we have defects with a buccal bone plate, which is at least 20 to 50% intact. There, we primarily go for a socket seal technique. And these are the materials which are well documented in the literature. And this can be done for any treatment. It does not even have to be an implant. It can be a pumping for a fixed reconstruction. It can be a resin bonded bridge, either a partial denture that we would like to maintain the alveolar structure. And when I have the time, Gerrit, I would like to have a little bit some philosophy.
Yeah.
When we look back in the 70s, in Switzerland, 1964, the 20 years old had a lot of caries. Then later on, we introduced in school kind of the prophylaxis to teach them what is bad for the teeth, what is good for the teeth, how we should clean the teeth. In 2018, the 20 years old, they have almost no caries. The caries prevalence dropped 93% down from 1964 to 2018. That's on the level of the tooth, just due to the fact that we changed our way how we look at things and how we train the people. And today, I do believe that the same thing should happen on the level of the alveolar ridge, that we need to limit invasive treatments for the future. Whenever we provide this to our patients, maybe there's a patient which needs to extract teeth and he's now in a position where he cannot afford implants. When he gets a ridge preservation procedure and he comes 20 years later, he's not facing a situation where I need to say, oh, listen, here we need to go to the maxillofacial surgeon in order to harvest hip bone in order to be able to place implant. By following this concept, I will be able to place implants in this patient's mouth without a huge invasiveness and without a lot of stress. And I maybe can do it by myself also when I would not be a great surgeon. It is a little bit more investment at the time of tooth extraction, but it serves the purpose of becoming overall less invasive. And when we follow that idea, we run out more and more of really invasive techniques. So that makes really dentistry all over the world kind of more predictable and less invasive.
Wow. I think that's an aim we should go for, right? What a pitch.
I think we definitely should.
It's on YouTube now, yeah.
So I would like to show you kind of 3 examples without going into details of patient which we apply now these thoughts. This is my favorite patient because he's the son of a dentist, the mother and the father are dentists, and he's a medical student. So it was very emotional.
What an audience.
He's very emotional because he started to lose his sensory incisors. He has 2 fistulas here and he has a pocket of 12 millimeter here. When we look at the cone beam CT, ladies and gentlemen, you can see a massive defect. The entire root is free of bone. There is everything in osteolysis. We only have a little bit of bone here on the buccal aspect. Even the lateral incisor involved. Luckily, the lateral incisor was still vital at that time point. And most likely, he has a fracture in this area here. But we didn't know that. So there was a big debate between the father and the mother. And I was more acting like a moderator in this situation. And the son was kind of just in between, not knowing who to believe. The mother said, no, we need to try to preserve the tooth. And the father said, no, look at this, we need to extract the tooth. Finally, we made the decision together with the endodontist, that this tooth has a fracture. And this was also true. We can see here clear the fracture line in this tooth. Now, what is the question, Gerrit? What I need to ask myself before I'm going to extract the tooth?
Are you going to be able to place the implant within 0 to 2 months?
You're my best student. So I need to ask the patient, I need to involve the patient. So he was in the middle of the medical exams. And he said, listen, I don't want to even think of getting an implant. Just want to get rid of this tooth, which is painful. And then I need to finalize my exams. And then I will come back I don't know when.
Sometime. Yeah, nobody knows when. Yeah.
So this is clear. I don't know when to do something. So it was totally clear that I will do a ridge preservation procedure. Also, it is not within the scope of the indication we talked before, where we say we need to have at least 50% of the buccal bone plate. But not doing it is just not an option, ladies and gentlemen. So that's what we did. When we here have the situation, we basically have then 3 options to treat it. We can use a graft material, and then we can place a collagen matrix, as we have seen before. Now we learn about when to use which material. Then we have the option to do a punch graft, or we have the option to do a connective tissue graft. Now each of them has his indications. You can always go for a connective tissue graft, but that doesn't make sense because it's the most technique sensitive, most invasive technique. And also when I would have a Formula One car, it doesn't make sense to drive every day to the university with a Formula One car. I need to customize my car to the situation. Mm-hmm. So we have learned when we do a collagen matrix, it's very good in terms of buccal dimension, but it does not increase the thickness of the tissue. And when we look at this case here of this medical student, we have a little bit of a soft tissue deficiency here. So we would like to increase this. So the best choice is to take a punch graft because we can increase this situation. And it's not extremely invasive compared to the connective tissue graft. I removed the tooth, cleaned everything. I'm going to go fast through it. And then 7 months, he did come back. And this is the situation. So we increased a little bit the area there, but we also lost here some volume because we have learned we cannot maintain 100%. We can only maintain about 85%. And when I opened the flap, this was the situation. So we have lost about 15%, but still we have such a nice ridge, which makes me in this, as you said, in this audience with the two dentists, kind of much less stressed, because everybody here now in tonight will agree on the fact that when I would have extracted that tooth and would have left it for spontaneous healing, we would be here in a situation where I have a minimal amount of ridge left, which would lead to a situation where I need to graft, which I need to do a major augmentation in order to rebuild the ridge. And just by making the right decision at the tooth extraction, change this case again from a very demanding case into a case where I can kind of straightforward place my implant in the area and a proper prosthetic position. And then I need to compensate for the last 50%. So I overcome to this case in order to come up then with a situation where we have sufficient tissue. This is the situation before placing then a one-piece crown. This is the situation which we were able to finalize a case in a very nice way because we did the right decision at the right time point. It's not because I was the most amazing implantologist or prosthodontist. No, it's about taking the right decision at the time of tooth extraction. It's a nice case to show this. And why do I love this case so much? Because he got really so much infected by the enthusiasm of being a dentist. So he switched from from medical school to dental school, and he graduated about 2 years ago at our university. I think he will be really a very comprehensive dentist, knowing to undergo such a treatment procedure.
Wow.
Maybe one more simple case, but also illustrating about the timing, which is so important. So here we have a fractured tooth. This is the first premolar. That would be, for me, an ideal case, for instance, for an immediate implant, when I would have sufficient bone. That's ideal. But before I do so, I need to ask myself, can I do an immediate implant, or can I do an intervention now? Now, the patient at that time, when she was pregnant, and she said, listen, I just need to extract the tooth because it's so painful, and then I will come back. I don't know why. It's my first child. I don't know how I can handle this. So this is also clear. I'm going to extract the tooth, and I will do a ridge preservation because I don't know when she's coming back. But I know when she's coming back, I will have a ridge, which enables me to place an implant in a pretty straightforward way. And here, in this situation, we don't need to go into any harvesting of autogenous graft, which is a little bit traumatic for the patient. Getting something from the palate is not that much fun. So here we go for the easiest way to do with the collagen matrix, because we don't need to increase the thickness of the tissue. We can stay at that level, or we can even lose a little bit without any compromise. So here, extracting tooth, cleaning everything, placing the graft material. This is the situation. 7 months later, she did come back, and there would be no need to open a flap that much, but it was for a research purpose in order to evaluate the buccal bone. A straightforward implant placed without any additional graft material, because here we can live with the 85% result. We are not in the central area. And this is the final result with this crown. And this is the situation 9 years later. She came back in January. She lives in Italy now. And look at how perfect this looks like. And again, the important part was the right decision at the time of tooth extraction.
Wow. I think you have a few very powerful messages here that we repeat over and over. It's the 50% loss in the first 6 months, right? That's important. That's one of the things we learned from the questions. It's about the decision. Can you go in or come back? Will the patient be eligible for the implant within 0 to 2 months? And otherwise, it's quite straightforward. Do the ridge preservation technique, correct?
Yes, maybe we can start to sum up a little bit. I think we come to the end. Maybe I'm going to show you the last one because it shows then kind of the complete picture. This is now a situation where we have a true soft tissue deficiency here. So here we need to compensate for really a defect. And here a punch graft is not ideal because it doesn't compensate for that much. And you often see then the transition line between the graft and the original socket in this area. A collagen matrix is not an option because we would like to increase the soft tissue. So this will be then the case where a connective tissue graft is the therapy of choice in order to compensate for this soft tissue deficiency. This has been done here. And then again, you can see this is how we have started. And within 3 weeks, we changed this critical situation into a situation which is much more straightforward to go on, to place an implant. This gentleman, he came back 8 months later. And you also can nicely see how the extraction socket, how nicely it has been maintained. And this is a difficult extraction socket because it is a little bit outside the alveolar structure. So it's like a balcony here, and it's much more demanding to maintain that. And again, we could easily place our implant there. We compensate for the 15% because we're in a central aesthetic area. And this is then the final situation with an implant here and a veneer on this situation. So when we sum up what you wanted to hear, Gerrit, I think it's pretty simple. The most important part we have learned is that the whole decision-making process takes place before I'm going to extract the tooth. And then the question, which we should never forget, is before I'm going to extract the tooth, I need to ask myself, is it possible or is it indicated to place an implant within the next 0 to 2 months? Whenever I have to say, no, I cannot place an implant for any reason we have seen before, then I think we cannot close our eyes and just let it heal spontaneously anymore. I think today we have enough knowledge to say, yes, in this situation, we do need to do ridge preservation. And then I come back to the question, how much residual bone it needs to be. To be honest, we don't have yet the evidence for a situation where we have more than 50% loss. But not doing it is, for me, ethically not anymore an option. Again, thinking of what I would do to my kids, I would not let that heal. In none of the case, I would not let that heal spontaneously. Also, when I only can maintain, 70% or 60%, it's even better than losing so much, which I never know how much I really lose. And this is then the situation where I need to choose which type of material I'm going to use. But when I can place an implant within the next 0 to 2 months, I can let it heal spontaneously. I can do an immediate implant, type 1, or I can do an implant 6 to 8 weeks later on. I have all the opportunities there. So one does not exclude the other. We just need to make the right decision. And here we only have one exception. And the exception is when I really have a soft tissue deficiency. Then an immediate implant is not ideal because I would like to compensate for this soft tissue deficiency by placing a connective tissue graft. And with this in mind, this was once a very kind of critical postgraduate student. After this, he was really happy because it's kind of a simple decision tree. And I hope I could really make you happy as well by providing you kind of information about this. It's a simple topic, but it's a topic which has a major impact on our patient's life and also our way how we treat patients.
Wow. Thank you for this very comprehensive wrap-up. To our audience, stay tuned a little bit because I'll let you know how you can share these learnings with your friends and colleagues throughout the world. But before I do that, I want to thank all the viewers who send in their questions. I want to acknowledge some people who did send in questions. For example, Soren Christie, I've seen your questions, but obviously this talk was going all over the place. So sorry if your question didn't get taken. And Jonathan, if you're still with us, Jonathan raised, he mentioned a study, a meta-analysis, and actually he got asked to share the link to the study. So Jonathan, if you're still with us, I think this is starting to become part of this EAO Just Ask experience as well, where we gather with this international crowd, and besides our experts, our viewers are also amongst each other, sharing knowledge and answering questions to each other. So thank you to all those audience members who actively participated. And obviously, thank you very much, Professor Ronald Jung, for sharing your knowledge and your preparations tonight. I see some great praise already coming through the comments. I think I should highlight to you that also Kobe Landsberg is saying thank you for the really great presentations, amongst many others. So if you're still watching, let him know what you thought about this, because he will read all this back, right, Professor? Now, This EAO Just Ask is now on the EAO channel. And if you're here for the first time, I invite you to subscribe. Hit the subscribe button on YouTube right now, so you'll be the first to know when a new video is published and when a new EAO Just Ask is about. Because this is our monthly live appointment. It's taking place basically every first Monday of the month. So that's easy to remember. We gather this great international crowd and we chat, we exchange, we learn, and this community is growing rapidly. So if you know anybody who might find this interesting, who might be interested in the topic of ridge preservation, please copy paste the link of where you're watching right now of this live stream, because this is also where the recording is available. You can share it with your network, share it with your friends, and make sure that as many people get access to this knowledge as well. And there's many more. We've been doing this for 8 months right now. So if you're interested to go deeper, for example, in the topic of soft tissue management, check out the session with David Nissan. Or you want to learn more about bone regeneration, the Just Ask with Isabella Rochetta, just go through the playlist and we have all the knowledge and recordings for you available there. And with that, well, Professor Ronald Jung, I hope you have marked in your calendar the date of June 1st, because then we have our next EAO monthly meetup, the Just Ask with Victor Palarie, where we're going to talk about systemic diseases. So thank you for now. Thank you for tonight. And we're looking forward to see you back there, both you and anyone watching right now. See you next time.
Thank you very much.